Hello everyone, I am Dr. Somya Govil from BBD College of Dental Sciences, Lucknow, Department of Periodontics and Preventive Dentistry. Today we will discuss about pulpectomy. What is the definition of pulpectomy? The complete removal of the necrotic pulp from the root canals of the primary teeth and filling them with an inert restorative material so as to maintain the tooth in the dental arch. As we all know, all procedures have their definitive indications and contraindications. Firstly, we will talk about the indications. The primary teeth with the pulpal inflammation extending beyond the coronal pulp, but roots and alveolar bone free of pathologic resorption. The second indication is the primary teeth with necrotic pulp, minimum root resorption, and minimum bony destruction in the bifurcation area. Primary teeth with sinus tracts. Primary molars when the arch length is deficient. Primary teeth where space maintainers or continued supervision is not feasible. Primary teeth without permanent successors. Primary second molars before the eruption of the permanent first molar. Primary teeth in hemophilics. Primary anterior teeth when speech, crowded arches, and aesthetics are a factor. Primary teeth next to the line of palatal cleft. Primary molars with support the orthodontic appliances. Coming on to the contraindications. Teeth with non-restorable crowns, periradicular involvement extending to permanent tooth bud, pathologic resorption of at least 1/3 of the root with a fistulous sinus tract, excessive internal resorption, extensive pulp floor opening into the bifurcation, young patients with systemic illness, primary teeth with underlying dentigerous cyst or follicular cyst. We will start with the axis opening straight away. What are the objectives of axis preparation? The first objective is to obtain a straight line axis preparation. Secondly, we need to conserve the tooth structure. The maximum tooth structure, the better we can. Then thirdly, we need to de-roof the pulp chamber to obtain, again, as I would say, a straight line axis preparation. Here we can appreciate the axis preparation given in the anterior teeth. As we can already look in the pictures given below, the first picture is of the maxillary teeth and the second picture is of the mandibular teeth. The anterior primary teeth, they usually have one canal, and the axis openings are traditionally made through the lingual surface. Next, we go on to the posterior teeth. The considerations before making an axis opening into the posterior primary root canals are the length of the crown, the bulbous shape of the crown, and the very thin dentinal walls of the pulpal floors and the root. Here we can appreciate again in the first picture the axis opening made in a maxillary primary molar, and in the second picture the axis made in the mandibular primary molar. Next we come on to the working length determination and instrumentation. Working length determination. It denotes the distance into the apical limit of the instrument. The reference point is the site on the incisal or occlusal surface from the measurement is made. The requirements of determining the working length are: firstly, it should be accurate. Secondly, it should be easily and readily performed. And thirdly, it should be easily confirmed. This is how we determine the working length in the primary teeth. Firstly, through our digital tactile sense, and secondly, through the radiographic method. Here we measure the radiograph with the help of our scale. We adjust it, the files, the instruments according to that, and then we determine the correct working length. Coming on to the biomechanical preparation and irrigation. What is biomechanical preparation? Biomechanical preparation is the debridement of the primary root canal, which is more often accomplished with the help of chemical means rather than by mechanical means. Why? Because there is the tortuous root canals present in the deciduous teeth. Copious irrigation during cleaning and shaping must be maintained. Here we do selective filing or circumferential filing. By this, we pre-curve the files and then we insert them for filing so that there are least chances of fracture. Irrigation. Instrumentation of the root canal system must always be supported by an irrigation system. Irrigation cleans the root canal space, making it bacteria-free. The materials used for irrigation are physiologic saline solution, hydrogen peroxide, sodium hypochlorite, EDTA gels, and of late we have started using chlorhexidine too. Instrumentation. The nickel titanium, or commonly known NiTi files, are recommended for deciduous dentition. Hand and rotary instruments are ideal for primary teeth. The canals are enlarged several sizes past the first file that snugly fits into the canal with a minimal size of 30 to 35. Sonic and ultrasonic cleaning devices and Gates-Glidden or piezo drills are contraindicated in a primary tooth. Coming on to the obturating materials. The first material we know is zinc oxide eugenol, the cry paste, the walk-off paste, Maestro's paste, Vitapex, calcium hydroxide, and iodoform paste. What are the properties of an ideal obturant? It is resorbable, it should be antiseptic, it should be non-inflammatory and non-irritating, it should be radio-opaque, it should be easily inserted, and it should be easily removed. What are the methods of obturation? In the past, we used to use different methods for obturation. We used to use endodontic pressure syringe, the mechanical syringe, the tuberculin syringe. There were jiffy tubes to be used. There was incremental filling techniques. And then finally, we started using lenturospiral technique. Coming on to the procedure of pulpectomy. We will first talk about the single visit pulpectomy procedure. The local anesthesia is administered. The pulp chamber is carefully opened with a high-speed burr. The spoon excavator may be used to clean out the pulp chamber. The pulp chamber is irrigated with the normal saline. A diagnostic file radiograph is taken. All the coronal and radicular pulp tissue is removed using the instruments. Irrigation is done to flush out all debris and dentinal shavings. We need to obturate the tooth completely, sealing the radicular and the coronal pulp chamber. Then we finally place the final restoration, and over that final restoration, we give a stainless steel crown. Now we would like to study about the procedure multi-visit. What do we do in the first visit? We need to administer local anesthesia. Then an endodontic access cavity is prepared using a high-speed burr. The pulp and the debris is flushed out by the irrigating solutions. The formocrozole pellet is placed in the chamber and then a temporary restoration is given. In the second visit, we remove the temporary restoration. Then we determine the working length with the help of a radiograph. We irrigate the canals with copious irrigation. Niti files are used for the shaping and cleaning of the root canals with copious irrigation. Here we can also use the rotary instruments to shape the canals. Dry the canal and again place a temporary restoration. What happens in the third visit? The patient comes to us. We need to evaluate the status of the tooth. That means the patient should not have any symptom of pain. There should be no pain present absolutely, because now we are going to place our final restoration. Before that, we need to surely check that the patient is totally asymptomatic. The tooth is totally asymptomatic. We re-enter by removing the temporary restoration placed in the previous appointment. We irrigate the canal with the help of irrigants and then subsequently we dry the canals. We prepare a thin mix of zinc oxide eugenol or any other medicament or obturating material to be placed into the root canal. Then we coat that mix of the medicament, the canal sealers, with a thin mix of cement, and then finally we fill the canals with the thick mixed cement. We compact the cement until no cement can further be incorporated into the root canals. Finally, what we do is to place the final restoration on the tooth, and then we go ahead with the stainless steel crown placement. This was the case which I had done in the department. As you can all appreciate that we have used the Niti files and then the final obturation has been done. After this, we placed our final restoration and then we placed the stainless steel crown. Just a brief insight again into pulpectomy. Here again, this is the picturesque part. In the first picture, you've seen the caries part. Clear all the remaining caries before removing the caries adjacent to the pulp chamber. Then remove the roof of the pulp chamber using the fissure burr. Remove the coronal pulp using a spoon excavator. And then with the help of your instrument, you need to remove the radicular pulp tissue. Then we use the file sizes up to the 30 number to clean the pulp chamber. We irrigate the canals with the saline solution. After we have cleaned the canal properly, we fill the canal with a slurry of zinc oxide paste. We fill the pulp chamber with the thick mixed cement. And finally, in the last picture, as we can all appreciate, the tooth has been given a complete restoration and the crown has been placed to give. There are the following differences between pulpectomy or primary and permanent teeth. The dentine walls in the primary teeth are very thin at the pulpal floor and that of the root. The dentine walls and the pulpal floor and the root are far more thicker in the permanent tooth. Depth to penetrate into the pulp is very less in the primary teeth. Depth to penetrate into the pulp is more in a permanent tooth. The working length is 2 to 3 mm short of the apex, because the rate of the resorption of the obturating material and the root does not match. And if we keep it 2 to 3 mm short of the apex, the material resorbs as the resorption of the root takes place. Working length is kept 0.5 mm short of the apex in the permanent teeth. The canals are enlarged, usually up to a size of 30 to 35 number in cases of primary teeth. And no specifications for the canal enlargement is given for the permanent teeth. Apex locators are generally not used for primary teeth. And we can use apex locators for permanent teeth. Gates glidden and piezo-reamers are contraindicated for primary teeth, while Gates glidden and piezo-reamers can be used for permanent teeth. The commonly used restorative materials for obturation in a primary tooth is a zinc oxide eugenol. And now the commonly used material, the restorative material for obturation is gutta percha in case of a permanent tooth. Here is where I end my lecture on pulpectomy. Thank you for your patient hearing.